Now look at this EKG rhythm in lead 2. Answer all the questions. Does it look like a sinus rhythm? Does it look like an atrial rhythm? Go through your questions to determine which it may be. As you guessed, the previous slide was not a sinus nor atrial rhythm. We're now going to be discussing junctional rhythms. In junctional rhythms, the SA node is not the pacemaker, nor is there a pacemaker occurring in the area of excitation in the atria. The pacemaker in this case is at the AV node or the AV junction, and that becomes the pacemaker of the heart. Remember that the SA node rate is 60 to 100 in normal conditions. The AV node or junction pacemaker rate is 40 to 60. We see junctional beats occurring due to areas of damage or because the SA node has fired to fail. We'll be looking at premature junctional contractions, junctional escape rhythms, and junctional tachycardias. When we look at junctional rhythms, we do have P waves, but they do not look anything like we have already discussed. If they are visible, they will be inverted. Remember that the AV node is the primary pacemaker in this case. In this first example of the EKG complex on the left, the atria depolarized before the ventricles. The AV node travels up into the atria, so the electricity is occurring backwards of what it should be occurring. Hence the inverted P wave in lead 2, and then it goes down to the ventricles. The picture on the right with the moving heart and EKG strip illustrates this. The second example, we do not see P waves at all. That is because the ventricles and atria are depolarizing at the same time. So it is hidden within the QRS complex. Remember that the AV node is what is depolarizing, and the electricity or current goes up and down at the same time. In the third complex on the left-hand side, you see an inverted P wave that is occurring after the QRS complex. In this case, the AV node fires. The electricity travels from the AV node down to the ventricles and then goes up into the atria, causing them to depolarize. We are looking now at a premature junctional contraction within a sinus rhythm. The premature junctional contraction is indicated by the green arrow. This 6-second strip is regular with the exception of that premature beat. The atrial rate is 90 and the ventricular rate is 100. In that junctional beat, we do not see P waves that are inverted either before or after the complex, meaning that junctional beat, the atria and ventricles are depolarizing at the same time. The rates can be normal or accelerated. It will be slightly irregular in pattern due to the premature beats. There is a P wave in front of every QRS complex in the underlying rhythm, but we don't see them in the junctional beats. And if we do, they will be inverted. There is a QRS complex after every P wave, and in junctional premature beats, we do have a complete compensatory pause. The PR interval is typically a little shorter in those junctional beats, but otherwise normal, and the QRS width is normal. Premature junctional contractions may occur in both healthy and diseased hearts. If they occur occasionally, they are insignificant. If they are frequent, they may result in junctional tachycardia, and treatment is not typically necessary unless the ventricular beats are greater than 150. This EKG strip is showing an junctional escape rhythm or junctional rhythm. The rate of the AV node or AV junction is 40 to 60, and it is our backup pacemaker in our heart. In this particular strip, we are looking at a ventricular and atrial rate of 40 and regular. The picture to the right illustrates what is occurring here. The electricity is going from the AV node up to the atria where the atria contract, and then down into the ventricles where they contract. Typically, it is slightly irregular. We already discussed how the P wave in front of the QRS complex is inverted. The QRS complex is after the P wave. The PR interval is shorter than the typical sinus beat PR interval, but it is going to still be less than 0.21 seconds if it is present. QRS width is normal, less than 0.12 or less. It is possible to have junctional escape rhythm with the P waves inverted but following the QRS complex, or absent if the electrical conduction is occurring simultaneously. Here is another example of junctional escape rhythm. The inverted P waves are indicated by the arrows. The first two complexes, they are inverted and preceding the QRS complex, but in the fourth complex, they come afterwards. The third complex, it is invisible, which means the atria and ventricles are depolarizing at the same time. The most common cause of junctional escape rhythm is sinus bradycardia. Remember that the AV node is the backup pacemaker in the heart, and when it does not sense sinus beats, it can kick in. It may be seen in the presence of a high degree or complete AV block, which we'll discuss later. If the ventricular rate is slow, the patient will have hemodynamic compromise, and we do need to treat the underlying cause and baseline dysrhythmias. Junctional escape rhythms of less than 40 are also called junctional bradycardia, and they will need to be treated, as the patient will be significantly hemodynamically unstable. Accelerated junctional rhythm is a junctional rhythm with a rate greater than 60 up to 100. This strip has rate of 80 and regular. We see that accelerated junctional rhythms are regular. P waves will be either inverted before or after the QRS complex, or they will be buried within and we will not see them. QRS is after every P wave when present. PR interval is typically shorter than expected, and the QRS complex is normal typically, although it may look a little wide if the inverted P wave is right on top of it. Junctional rhythms with a rate of greater than 100 are considered junctional tachycardia. The significance of this is the rhythm is depending on the basic disturbance. If the ventricular rate is rapid, the cardiac output may decrease, as in previous examples. Then treatment is indicated, and that would mean needing to find and treat the underlying cause of the accelerated rate. As previously mentioned, junctional tachycardia is a junctional rhythm with a rate greater than 100. In this EKG strip, you are seeing atrial and ventricular rates at 150, and it is regular. Note the inverted P waves in front of each QRS complex. The rhythm is regular. There's a P wave in front of every QRS complex, although inverted. If it occurs afterwards, it will be inverted, or it may look absent because it will be buried within the QRS complex. There is a QRS after every P wave when present. The PR interval is typically shorter than a normal sinus beat. The QRS complex may appear widened depending on where the P wave occurs. Clinical significance will depend upon the basic rhythm disturbance. If the ventricular rate is rapid, the cardiac output may decrease and the patient may become hemodynamically compromised. The treatment would be indicated, which would be finding and correcting the underlying rhythm. Supraventricular tachycardia is a tachycardia that is occurring above the ventricles. Supra, meaning above the ventricles, is not a sinus rhythm, and it is not a ventricular rhythm. So it is either atrial or junctional. When you know that it is not sinus nor ventricular in origin, but you cannot yet determine what it is, you do know that because the narrow QRS complex, the pacemaker is above the ventricles. Therefore, until you slow it down, you will not be able to determine the pacemaker site. So we call it supraventricular tachycardia in this case. Here's an example of supraventricular tachycardia. In this case, the ventricular rate is 180. There may or may not be P waves present as indicated by the green arrow. We can't really determine in the second EKG strip if there are P waves at all. At least the top one, there's a guess that there may be. The bottom EKG is a ventricular rate of 200. Both strips have regular rhythms. We know because the QRS complex is narrow and upright in lead 2 that is predominantly going to be either atrial or junctional in origin. The rate is too fast to be sinus rate, and the complex is too narrow to be considered ventricular. Now it is your turn to try to interpret a few examples of EKGs. The answers will appear after about 1 minute. If you need to go back and review the slides again, then go ahead and do that.